So today's online lecture is going to be discussing Chapter 6, and Chapter 6 is entitled Breathing and Ventilation, which is in your textbook. I think that when we think about breathing and ventilation, I think that it's one of the most important jobs that you'll do as a first responder, which will involve some type of patient airway assessment and breathing assessment, right? And so no matter what a patient's problem may be in an emergency situation, you first must determine if a patient has an open airway, if that airway is clear, and whether or not they are truly breathing adequately. And so what do I mean by adequately? Well, I mean, are they breathing deep enough to bring in enough oxygen to supply the brain with what it needs to sustain life? And assessing breathing and assessing an open airway really can spell the difference between life and death in an emergency situation. I think when we think about the respiratory system in general, what is interesting to know is that the body can store food for weeks and the water that we drink for days. However, it can only store enough oxygen for only a few minutes. And so when we think about the respiratory system and we think about the process of breathing, it really is this intricate process that is very, very important to us as human beings in order to sustain life. And so what's the purpose of this online lecture? Hopefully it'll help you focus on the anatomy of the respiratory system, but that also would provide information on airway techniques and procedures, such as how to open the airway, how to assess patient breathing, and most importantly, how to perform an artificial ventilation in adults and children who may not be breathing at the scene of an emergency. So there are several different major components to the respiratory system and that help with the breathing process. And those major anatomical structures are obviously the nose, and then you got your mouth, right? We breathe in through our nose, we breathe in through our mouth. So those are two major anatomical structures that are going to be responsible for bringing in oxygen into the body, right? But then on top of the nose and the mouth, we also have other anatomical structures that play a huge role in breathing or the respiratory process. And those anatomical structures include, but are not limited to, the pharynx, which you guys would know in layman's terms as your throat. Then we also have this little guy here called the epiglottis, and we'll talk a little bit more about the epiglottis in detail and its major role within the breathing process and the eating process. After we look at the epiglottis, we also have the larynx, which is your voice box, right? So singer, if we have a singer who, let's say, gets laryngitis or an inflammation of the larynx, they lose the ability to sing as efficiently as they would. And then after the larynx, what we also look at, which is not represented on this particular figure, are the bronchi, the lungs, and the diaphragm, right? And we'll talk about those more throughout this lecture when we get to that particular slide. But all in all, there are 5 major anatomical structures within the respiratory system that help and aid in the efficiency of the breathing process. If we have injury to any of these structures, so the nose, the mouth, the pharynx, the epiglottis, or the larynx, then the process of breathing could become labored and or more difficult for our patient. So the first 2 anatomical structures that we're going to talk about are the nose and the mouth. And the reason we start with the nose and the mouth is because this is really where respiration begins, right? So we would say that this is the starting point for respiration, which are the nose and the mouth. So when you think about the nose and the mouth, we obviously think that their most simplistic role in the respiratory process would be to just bring oxygen into the body. But the nose and the mouth also serve several different other roles. And those roles really are, what it does is the nose and the mouth are really going to warm the air that's coming into the mouth. They're going to moisten the air that's going to be filtered into the pharynx and then the larynx and then to our bronchi. And they're also going to filter the air as it flows over the damp, sticky mucous membranes of both the nose and the mouth. So if we could do a recap, what we would say is that the nose and the mouth serve other functions besides bringing air into the body. And those other functions are to warm the air that enters through the mouth and the nose, to filter the air that enters through the mouth and the nose, and to moisten the air that enters into the mouth and the nose. And I think when we think about the most important role or function of the nose and the mouth, I happen to think that it's filtering, right? So that in this process of breathing, that we would be filtering out any pathogens that might be trying to enter into our body. And if we filter out the pathogens, then we reduce our patient's chances of suffering from some type of illness and or pathology from a pathogen invading our body. So again, the nose and the mouth are more than just serve more of a role than just bringing in air into the body. They are warmers of air, they are filters of air, and they also moisten the air that we are bringing into our body. So in other words, they really serve the role of preparing the air to be delivered to the next anatomical structure. So, located at the back of the nose and the mouth is what we would consider to be the pharynx, right? And the pharynx or the throat serves as the passageway for both food and air. Air from the mouth enters into what we would call the oral pharynx, and then air from the nose enters into the nasal pharynx. So, once again, if we think about the anatomical structure of the pharynx, we would say that then that anatomical structure pretty much makes up the posterior aspect of the throat, and it is an extension of both the nasal cavity here and then also the oral cavity, which would be here. So all air coming in from the environment to the nose and the mouth will either enter into the nasal pharynx and or the oral pharynx. At its lower end, the pharynx divides into two divisions, and one of those divisions is the esophagus, which we see way distal, so way down here, and then the other division is the trachea and or what we would call the windpipe, which is here, and then these two divisions pretty much serve as a passageway, or at least the trachea serves as a passageway to the lungs, where air would then be distributed to the rest of the body. So again, if we could think about the pharynx, the major role of the pharynx is really to serve as a conduit from the nose and the mouth down to the trachea, which would then deliver air to the lungs to be distributed to the rest of the body. The major player in the game, the connector piece, is the pharynx, right? It's located posteriorly. Air is going to travel down the pharynx into either the esophagus and or the trachea. Remember, air will go through the trachea, and then food that would be digested is going to go down to the esophagus and or what we would call the stomach. Okay? So the next anatomical structure that we'll talk about is the epiglottis, and the epiglottis really does play a major role in the respiratory or the breathing process. And when we think about the epiglottis, it's a flap of cartilage that is located in the throat, and it's located behind the tongue, but also in front of what we would consider to be the larynx itself. And so typically in an upright position, or when the larynx is at rest, it's in an upright position. And what this does is it allows air to pass into the larynx and then go down into, we'll say this way, into the lungs. And so when a person swallows, the epiglottis tends to fold backwards to cover the entrance of the larynx so that food and liquid do not enter into the trachea, right? We don't want food and liquid to enter into the trachea. We can kind of think of the time when we're laughing or joking and we swallow some food and it kind of goes down what we consider to be the wrong pipe, and we start to feel this burning feeling or sensation within our throat. Well, then you could blame that on your epiglottis, because your epiglottis at that point in time wasn't functioning correctly. And what that means is that food and or liquid that you were drinking went down the trachea instead of going down into the esophagus where it was supposed to go. So we can think of the epiglottis as a director, right? In the sense that if it's in the upright position, when we are swallowing and or drinking, it will prevent fluid and food from going into the trachea, and it will allow that fluid or food to pass into the esophagus, where it can then be digested and or excreted via the urinary system. So the epiglottis's major role is really prevention of fluid into the trachea, and it does that by sitting into an upright position. However, there are situations that may arise where during, let's say, illness and or injury, that the epiglottis's reflex may not work properly, and in that case it may cause your patient to aspirate, or what we would say to vomit, or to inhale liquid, blood, and cause vomiting into the trachea and the lungs, which is a huge deal, because then that can cause some type of breathing obstruction. It can lead to infection and also can lead to death if the patient stops breathing. So we have to rule out any injury and or illness involving the epiglottis, because if not, it cannot function correctly. So if we were to trace the process of respiration, what we would say is that air could either enter into the nasal cavity and or the oral cavity, and then via either the nasal oral pharynx, or the nasal pharynx or the oral pharynx, we would then have air being transferred down into what we consider to be the larynx, and then into the trachea, right? And so we kind of have to talk about both anatomical structures, which are the trachea and the larynx. And so when we think about the trachea, another name for trachea is what we would call the windpipe, and it really is responsible for carrying air from the nose and the mouth to the lungs directly. And so the trachea really serves as a transportation site of air to the lungs, right? It's going to be responsible for delivering O2 to the lungs. And so when we think about that importance, if our trachea isn't functioning correctly, then we don't get enough O2 going to the lungs. And the lungs are responsible for obviously delivering or transporting O2 to different tissues or different sites within the body. So we have to have this process of breathing in which air goes from the nose into the mouth, and then into the nasal and oral pharynx, and then into the trachea where it can be distributed to the lungs. This anatomical structure here, which is the larynx, is, we consider it to be what we call the Adam's apple. So if we were to lift up our chin right now and to fill our larynx, we would call that the Adam's apple or the voice box itself. And it can be easily felt again with your fingertips in the front of your throat. It is the anatomical structure that protrudes as you lift your chin into the air. So what's the role of the trachea and the larynx? Really is to deliver oxygen to the lungs where it can be transported to the rest of the body to supply the body with oxygen. So what we can say is that a variety of diseases and injuries can affect the patient's ability to get enough oxygen to the brain, to the heart, and to the musculoskeletal tissues. And so one big thing to consider and to think about is that without oxygen, the brain cells begin to die. But not only do brain cells begin to die, the heart's cells begin to die as well. And this cell death can start to occur within minutes. And so for you as a first responder, rapid treatment is going to be essential, right? And so one of the biggest things about the brain, it's the control center for breathing. And so it typically has the ability to really adjust the rate and the depth of breaths according to how much oxygen and carbon dioxide are being brought into the body and being removed from the body through the process of inhalation and exhalation. So we think about the breathing process. Yes, we've talked about the anatomical structures such as the pharynx and the larynx, the mouth and the nose, but what we really have to take into consideration is truly just the fact that the process of breathing really requires several different human body systems to function in order for respiration to occur. And obviously when we think about breathing, the respiratory system is the number one human body system that we would think of, but then there are other human systems that we don't tend to think of, such as the circulatory system, right? Once we bring in oxygen, that oxygen goes through the nasal pharynx, the oral pharynx, and is delivered to the lungs via the trachea and the larynx, then the circulatory system has to be functioning enough to pick up the oxygen that's being delivered and to transmit that oxygen to the musculoskeletal system or the other tissues that might need it. And then we also have to have an intact nervous system as well. So what we can say is that the process of respiration really is a complex task that requires more than one human body system to be functioning. Now, we might imagine that if we had a compromised, let's say, circulatory system, that even if we were breathing appropriately at the appropriate breaths per minute, that if our circulatory system isn't picking up the oxygen and isn't delivering it to the desired or target tissues, then we still might have a lack of oxygen to that anatomical structure. So here's a breathing schematic that to me really determines whether or not our patient survives. And so when we look at this clock, what we kind of think about is how much time do we have to get or introduce some type of oxygen to our patients so that they might actually survive the emergency situation. So when we look at this clock, the first thing we look at is 0 minutes, the 0 minute time frame. So this is when your patient stops breathing, and then eventually when patients stop breathing, there's no oxygen circulating. So remember, we said without oxygen circulating, typically the brain cells start to die, and eventually the heart's cells begin to die. And so eventually what you have, really, these two things go hand in hand. When breathing stops, eventually the heart will stop beating. And so now we have no oxygen being delivered to the body, and then we also have no blood flow going to the body as well. And so within 4 to 6 minutes, if we don't start rescue breathing or we don't start some type of oxygen delivery, what they say is that brain damage is possible, right? So there is a low % chance that our patient might have some type of brain damage if we don't introduce oxygen within the first 4 to 6 minutes after they stop breathing. And so when we get into the 6 to 10 minute time frame, where we really start to be concerned because brain damage is likely. So we've just now increased the patient's chances of at least having some type or some sort or some percent of brain damage. Here's where you really want to be concerned as a first responder. It's here. When we haven't started treatment, we've taken too long to do our initial assessment, and it's been well over 10 minutes that our patient hasn't been breathing and their heart hasn't been beating, that you get irreversible brain damage. And so it's in this area that we want to focus, because as a first responder, our goal should be is to really deliver some type of treatment. So we'll say treatment to our patients within 4 minutes. Well, why do I say 4 minutes? Well, because that's the threshold. That's when brain damage is possible, right? We really want to operate in an environment where we're treating our patients, where we're delivering oxygen within 4 minutes. If not, then we know that more than likely our patient will have some type of brain damage, or at least a low percent of brain damage when they do come back to consciousness. So why do I show you the schematic? Because it's very crucial and important that we're able to assess, that we're able to evaluate our patient's breathing, whether or not they have an open airway. And we really need to be able to do this and the initial assessment within 4 minutes. If not, then we know that our patient may have some brain damage. So what can cause some breathing emergencies, or what would be a reason that someone wouldn't be breathing or wouldn't have efficiency in their breathing? Well, one of the most common reasons for a decrease in breathing or ineffective breathing is an obstructed airway. And so by obstructed airway, what I mean is either they are choking on something, that their tongue is blocking their airway, whatever it is, the object or the tongue itself, it is obstructing the airway, and it's decreasing the ability of the mouth and the nose to move air from that anatomical structure into the trachea, where it can be delivered to the lungs. So that's one reason. Another reason, which we've most commonly dealt with on this campus, is illness, right? And so when we think about illness, think about that time when you've gotten that really bad stuffy nose, or you've gotten a case of strep throat and you just can't breathe or swallow because it hurts so bad. So illness can be another reason that we would have or suffer from some type of breathing emergency. Also respiratory conditions such as your asthmas or your chronic pulmonary diseases such as emphysema, so patients who are chronic smokers. And so we can look at this list of breathing emergencies and we can say, okay, these are things that we might encounter as a first responder in an emergency situation. Well, why do we need to know this list? Well, one of the reasons we need to know this list is because we need to know what things might potentially affect a patient's ability to breathe. We need to know which things might be causative factors for blocking an airway or the inability of you as a first responder to get breaths in. And so this is why I give you this list, because I think it's important for us to recognize some of the common breathing emergencies, especially in San Diego, where we're close to the ocean. Another common reason that we see breathing emergencies is drowning, right? So when we think about drowning, water gets into the lungs, the lungs become filled with water, and as a result, we can't move air into the lungs because they are blocked or filled with water, and so we get less oxygen being delivered to the body that way. Other reasons for breathing emergencies will be heart attack, which we'll talk about in chapters 8 and 9 more specifically, and then this thing called allergic reactions and or what we would call anaphylactic shock, which is an extreme or a severe allergic reaction to, let's say, either a bee sting or some type of food. So yeah, your bee sting here and or food allergies. Either way, it's a medical emergency, and it can impede the airway and reduce a patient's ability to move oxygen into the body effectively. So the process of breathing really involves this muscle called the diaphragm, which we'll see down here in a circle down below. The diaphragm is a large dome-shaped muscle that contracts and flattens during inhalation, and this kind of causes the chest cavity to expand. When you think about the diaphragm, it is the major muscle of respiration. If it is not functioning properly, then we really don't have the ability to move air or oxygen into the body as efficiently as we would as if it were to function properly. And so again, the diaphragm itself is large, it's dome shaped, it sits right underneath or just posterior to the rib cage and the thoracic cavity. And again, it's going to contract. It's going to flatten during exhalation. What this does is it kind of simulates or causes the rib cage to expand, which allows the lungs to fill with oxygen, right? This maneuver kind of creates a vacuum, which pulls air into the lungs. And then on this side, we would say during exhalation, what we get is the opposite. The diaphragm relaxes. It goes back to its previous shape, which is a compressed shape. And by doing that, by allowing the rib cage to come back to a resting position, the air is then forced out of the lungs, right? So our CO2 is now leaving our body and going back into the environment. So when we think about the process of inhalation and exhalation, the far left figure is going to represent inhalation and the far right figure is going to represent exhalation. When we think about inhalation, the diaphragm and the muscles between the ribs are going to contract, and by doing this, it's going to increase the size of the thoracic cavity, making it possible for the lungs to expand. During this process of inhalation, the diaphragm moves down slightly and it flares the lower portion of the rib cage. And then by doing this, it kind of moves upward and outward. And so what we get is kind of like this, what we would call decrease in pressure within the chest cavity. And this decrease in pressure causes air to flow into the lungs. So this process of respiration, again, it's very complex. Not only does it involve the musculoskeletal system, the respiratory system, the nervous system, it also involves this intricate muscle called the diaphragm, right? And if it's not functioning or if it's spasming, then it is not capable of expanding the thoracic cavity. Therefore, we don't get a decrease in pressure and we don't get as much air moving into our lungs. In the lungs, what we would say is that gases pass through the thin walls of both the alveoli and the capillaries, and then oxygen enters the alveoli during inhalation, passes into the capillary walls, into the bloodstream, right? So there comes that circulatory system, which is then going to circulate the oxygen throughout the rest of the body. And then the opposite end of that spectrum, during the process of exhalation, what we would say is that the diaphragm and the muscles between the ribs relax, and so we get this decrease in size of the diaphragm itself. This decreases the size of the thoracic cavity, so again we get a decrease in the size of the thoracic cavity, and so this is beneficial because it increases the pressure, and so the diaphragm moves up, the ribs move down and in, and air flows out of the lung because we get this pressure being placed on our lungs, and so we get this expulsion of CO2 back into the environment, right? So why do I tell you this? Because the diaphragm plays a huge role in respiration. When it contracts, it causes expansion of the thoracic cavity. By expansion of thoracic cavity, the air is allowed to enter the lungs because there's a decrease in pressure. However, when the diaphragm relaxes, the chest cavity or thoracic cavity goes back to a resting position, and that places pressure on our lungs and it forces air or carbon dioxide specifically back into our environment. When you encounter a child or an infant, it's very important to understand that there are definitely anatomical differences in the airway and their structuring when you compare it to an adult airway itself. And so when we think about a child or an infant, we have to remember that the anatomical differences in their respiratory system do exist, and we have to acknowledge those. So all of the structures, including the mouth, the nose, the pharynx, the larynx, all of these respiratory anatomical structures are definitely smaller than adults. They are more easily obstructed by even small objects, blood, and or swelling. And so we have to take extra care to keep the airway and the airway open in infants and children because their airway is fragile and because all the respiratory anatomical structures are so much smaller, right? And so the tongue of an infant or a child takes up proportionately more space in the pharynx than the tongue of an adult. And so it therefore can block the airway a lot more. So I think about this, they have larger tongues, and because they have larger tongues, that larger tongue can actually aid as a block in the airway because it can slide back into the posterior portion of the throat and block the pharynx, right? Remember, we said in the anatomical portion of this lecture that the pharynx is located just posterior to both the mouth and the nose. So if the tongue falls to the posterior portion of the throat, then essentially we're blocking off the pharynx. Now remember, the pharynx is the gateway between the trachea, right, and the larynx, and so the trachea responsible for delivering air to the lungs, and so if the pharynx is blocked off, then we lose the connection between the pharynx and the trachea, or the lower end of the respiratory system. So the tongue is larger in infants. We would say that the trachea of an infant and a child is narrower, and it's also more fragile than an adult. And so it's softer and it's more flexible. And so we think about opening the airway. If we tip the head back too far in a child and an adult, what can happen potentially is it can actually close off the trachea. So the rule of thumb in opening up an airway for a child is just to open up the airway just past neutral. Whereas in our adults, we can open up the airway or tilt the head back as far as we would like without having to worry about blocking off the trachea as well. And so other things that we could look at is, we said the trachea is definitely more narrow and flexible. Then we have the cricoid cartilage, which we'll do in lab. It's less rigid and less developed. So again, it is more susceptible to fracture. It's more susceptible to being injured when we open up the airway. The obvious, I think, is that their mouth and nose are a lot smaller. And so they tend to potentially bring in, or can only hold in less, or can hold in less oxygen than adults could during the breathing or respiration process. And so we think about these anatomical differences. It's the major reason that we don't tilt the child's head back as far as we would with an adult. We have to be a lot more careful when we're assessing the airway, when we're assessing the breathing in an infant and a child, than we would with an adult. And so these are the major anatomical differences in airway. Big deal is whether your patient is an infant, child, or an adult. Remember that the family members also may need you. So be calm, be caring, as well as professional, and then place your patient's interests first, but consider the family as well. So I keep talking about inadequate breathing or inefficient breathing. So what is adequate breathing? Well, the normative values are listed below in the table, and you see them here. For an adult on the lower end of the spectrum, about 12 to 20, your 12 breaths per minute would probably represent someone who's very active, collegiate level athlete, Olympic level athlete. For your child, we're looking at about 15 to 30 breaths per minute, and then for your infant, even faster, so about 20 to 50 breaths per minute. When we think about breathing being adequate, we would say that there are several different key factors that would predict whether or not breathing is adequate, right? And so we would say that those three factors are whether or not it's a regular rhythm, whether or not there are no unusual sounds, and whether or not the chest expands. So when we think about unusual sounds, we're thinking of sounds such as wheezing, or gurgling sounds, right? Whistling sounds. Again, with the chest, remember the diaphragm, we want it to expand, right? And if the chest isn't expanding, then that means that the diaphragm isn't contracting, right? And so the chest isn't expanding, the diaphragm isn't contracting, then what that basically means is that we're not decreasing the thoracic cavity pressure, and so we're not getting as much air into our lungs. And then as far as regular rhythm goes, when we think about regular rhythm, is it fast? Is it slow? What does it look like? So we got sounds, we've got chest compressing or expanding, and we got regular rhythm. Those are the three things that will help us determine whether or not a patient has adequate breathing. So when we assess breathing, we need to look for regularity, we need to assess for sounds, and we need to determine whether or not the chest is expanding and or rising. So I've told you what the signs of adequate breathing would be. So what are the signs of inadequate breathing? And so when we kind of look at the definition of inadequate, what we would say is anything that falls outside of the normative values that were given to you, right? And so for adults, that would be anything where the breathing is less than 8 beats per minute, or breaths per minute, sorry. For a child, it would be anything where it's less than 10 breaths per minute. And then for an infant, anything less than 20 breaths per minute. If we are assessing the rate of a patient's breathing, then we really want to know, do they fall outside of the normative values that were established on the previous slide? And if so, then we would say that this patient isn't breathing fast enough to bring in enough oxygen to supply the rest of the body. I think the next thing that we said is whether or not the chest rises and falls or whether or not the chest expands, right? We're concerned about chest wall motion because what chest wall motion tells us is whether or not the diaphragm is expanding like it's supposed to expand. Remember, if the diaphragm expands, then the thoracic cavity, specifically the lower portion of the rib cage, can expand. And by expanding, we can allow air or oxygen specifically to come into the lungs to be delivered to the alveoli, the capillaries, and into the circulatory system as well to supply the rest of the body. And so a sign that we can look for is what we call cyanosis. And this is representative of a patient who is not getting enough oxygen, right? So there's decreased oxygen being supplied to the body. What cyanosis is a patient who presents with and or looks what we would call blue. A blue colorish appearance would mean that a patient is not getting enough blood flow and or oxygen to that specific body part or to the body itself. In your darker complex patients, you do have to be concerned because obviously African American patients in particular will not present with a bluish appearance. Instead, they might present with a grayish appearance, and so that would be considered cyanotic as well. So in your lighter complex people, we're looking for someone who's cyanotic. In your darker complex people, you might be looking for someone who looks what we would call gray and or ashen. Also on this list, we could think of patients who are having what we call mental status changes. Remember the AVPU. So we have alert, we have verbal, we have painful, we have unresponsive. A patient who goes from being completely alert and then at your 5-minute assessment goes to only being alert to verbal stimulus. At your next 5-minute change or check goes to being alert to painful stimulus and then eventually becomes unresponsive. So if you're dealing with a patient who is slowly deteriorating and you're noticing mental status changes, then this might be a sign and symptom that your patient isn't getting enough oxygen or isn't breathing in enough oxygen to supply the brain and the heart, right, so that they can function. And then when we think about other signs of inadequate breathing, the other two really are gasping and grunting, which we've kind of talked about on the other slide. And then eventually, remember, if breathing is ceasing, if breathing is slowing down, then eventually what you start to have happen is the heart starts to slow down as well, and eventually the heart will stop beating at some point in time if the patient isn't breathing efficiently. Now remember the clock. At 0 minutes, we are in the safe zone. We can evaluate our patients, but it's at 4 minutes that we start to become concerned because there is a slight chance that our patient might have some form of brain damage. So always remember that clock in your head as you're doing the initial assessment. So we're going to be talking about this concept of dead space and breathing. And so what I want to tell you guys right now is that there are times when a patient appears to be moving air in and out of their lungs, but the amount of air in each breath is simply not enough to sustain life. So this patient may present to you like they're moving in air. However, when you meet with them, when you ask them questions, they still are not cognitive. They still seem like they are not as alert as they should be, even though they appear to be breathing adequately and efficiently. So there really are two factors that determine what is enough in terms of bringing in oxygen, and that is really the rate and the depth of breathing. And so we'll say rate of breathing and then the depth of breathing, right? And so these two factors really help determine how much oxygen is really being brought into the body. And so to be adequate, breaths must be of sufficient rate, and they also have to be deep enough to get air to the alveoli for the exchange of gases to occur. So not only do we have to be breathing fast enough and adequate enough, but they also have to be deep enough to get the air down to the level of the alveoli for gas exchange to occur. And if these two factors are inhibited, then you don't get enough oxygen going down to the alveolar level for gas exchange to occur, and therefore you don't get enough oxygen being delivered. So this is the concept of dead space. And so we think about dead space, we think about is how much air that we are breathing into our body actually gets delivered to the alveolar sacs, right? Versus how much air just stays in the lungs and does not reach the alveoli for gaseous exchange. And the average amount of air that we breathe into our body that does not get delivered to the alveolar sacs is about 150 milliliters per breath. So we think about this in the big scheme of things. Let's just say that we had a patient, a normal adult patient, who was breathing about 12 times per minute, and they were taking in about 500 milliliters of air. What we'd say is that of that 500 meters of air per breath, that approximately 350 milliliters of air actually reach the alveolar sac, while the other 150 stays within the lungs themselves, right? So we get the 150 just staying in the lungs and not being delivered to the alveolar sacs, whereas we get the rest of that breath, right, that 350 milliliters actually being delivered to the alveolar sacs for gaseous exchange to occur. So even as a healthy human being, we say that 150 milliliters per breath is not being delivered to the alveoli, right? So we can imagine that in an emergency situation, that even more oxygen is being stuck in what we would consider to be dead space. That in fact, you get it to the level of the lungs, however, it just cannot be distributed to the alveoli or the alveolar sacs. And the main reason is because either the rate or the depth of the breath was not efficient enough to bring it down to the level that we need it to be down to. So what is dead space? Dead space is the space or the area in the lungs where at least 150 milliliters of oxygen and or air is not delivered to the alveolar sacs for gaseous exchange to occur. It happens in normal human beings, but we need to take into consideration that it's probably going to be well above 150 milliliters in our emergent patients, so in an emergency situation. So this is where artificial ventilation comes in, I think. If a patient is not breathing adequately or is not breathing at all, the patient needs your immediate assistance. Remember, we have about 0 to 4 minutes to deliver some form of oxygen to our patient before brain death is likely, right? And so artificial ventilation is really a way of breathing for our patients who are incapable of breathing adequately or incapable of bringing in enough oxygen to the alveolar sacs for gaseous exchange to occur. And so when we think about inhaled air, right? We think about the air that we actually currently breathe. We think about how much oxygen it really contains, right? And so inhaled air contains about 21% of oxygen. And the interesting thing is that the body only uses about 5% of that 21%. And that's all it needs to sustain life. And then that remaining 16%, you might say, well, what happens to it? Well, that remaining 16% just gets exhaled the next time we exhale. So I find that to be interesting. Since the air you breathe into a patient contains more than enough oxygen to keep him or her alive, then what we can say is that artificial ventilation is more than sufficient to sustain a patient's life, okay? And so again, so what does this mean for our patients? We're breathing in 21%, the body only uses 5%, and it exhales the 16%. What this means for our patient really is that artificial ventilation is crucial to life support until O2 arrives. What that means is that you breathing for your patient will do more for your patient than not breathing. So that anytime we don't have an open airway, our patient isn't breathing, we have to begin the process of artificial ventilation. For those of you listening to this lecture who do not know what artificial ventilation is, it's the process of breathing for our patient. It is not oxygen administration. It is actually you doing either mouth to mask breathing and or mouth to mouth breathing for your patient to sustain his or her life until O2 arrives. So breathing for your patient would represent artificial ventilation. So now we're going to talk about airway techniques, how to open the airway, what things we could be using to breathe into our patients. And so the first question that I always ask is really, what is the most common cause of an airway obstruction? And if you don't know the answer to that, the most common cause of airway obstruction is the tongue. The reason being is because when we become unconscious, the only way for the tongue to go is into the back of the throat. So simply just doing the head tilt chin lift most times will remove the airway obstruction. It will open the airway up for our patient, and it will allow the patient to get some type of O2 delivered to the lungs and to the alveolar sacs. So what are the two techniques that we discussed that can be used to open the airway? Well, it's very simple. The number one technique, the only technique that we commonly use, is the head tilt chin lift. So let's move that back. It's going to be the head tilt chin lift. And then the other technique, which we only use with spine injured, head injured patients, is the jaw thrust technique. And we'll do both of these in lab tomorrow when I see you. But the jaw thrust technique, again, is only used when we have someone that we suspect has a C-spine injury and or a head injury. And remember, we're simply just sliding that mandible forward. There is no movement in the neck whatsoever. And then with the head tilt chin lift, again, we're moving the chin up towards the ceiling in hopes that we would open up the trachea, the pharynx, and the other respiratory anatomical structures. And so airway techniques, we're going to get into those right now. So the first thing that you want to do as a first responder is you want to put on gloves, right? Remember, always protect yourselves from pathogens. The best way to do that in the field is to put on gloves. The next thing that you want to do after you have on your gloves is you want to put your fingers in the patient's You want to put your fingers in the patient's mouth and you want to open the patient's airway. The reason that we want to do this is we really want to look inside of the patient's mouth to make sure there isn't any food that might be obstructing the patient's airway. One suggested technique to use is what's called the crossed finger technique, and we'll do this in lab again, but basically it's where you would cross your index finger over your thumb, put your thumb on the bottom row of your patient's teeth, and then your index finger making contact with the top, and then you just spread that crossed finger open, and that allows you to look into the patient's airway and get a good visual for anything that might be obstructing your patient's airway. The big deal during this process, during the inspection of the airway, is you want to make sure that as you're inspecting the internal airway that you're also looking and listening for snoring, crowning, gurgling, stridor, any other abnormal breathing sound that might be a hint to you that there is an obstruction in your patient's airway. So if in fact you do notice that an object is obstructing the airway, the rule of thumb is to place the patient into a recovery position. And so what you see down here is a first responder who is rolling the patient onto their side. When you roll the patient onto their side, you've now placed them, or at least their head, in a gravity dependent position where the head is now being forced down towards the ground and gravity is assisting us with anything that we might need to remove from the airway. So what we're going to do is we're going to place that patient in a recovery position, and then we're going to do what we call a finger sweep. It's just in this picture right here where you take either the pinky if it's an infant or the index finger if it's an adult, and you sweep the back of the airway to try to get the obstruction or try to remove the obstruction from the airway. And so what type of patient goes into a recovery position? It's very simple. A patient who is unconscious and is not breathing, whom you have to leave to go call 911. The big reason that we do this is because if they vomit, they will choke if they are lying on their back. They will not choke if they are in the recovery position, because the vomit will then go towards the ground. And then what type of patient needs a finger sweep? Well, that's a patient who has some type of airway obstruction. You've inspected the airway, you see something in the back of the throat, you're going to go ahead and do a finger sweep. Otherwise, if you do not see an object, if you're not leaving your patient, then we are going to provide artificial ventilations for our patient unless the scenario changes. So when we assess a patient's breathing, the big deal is, first of all, are they conscious? If they are conscious, the big question that we have is, can they speak? Can they talk to you? Can they answer your questions? If they can complete sentences, if they can speak to you, then we would say that that person is breathing, right? If the patient, on the other hand, can only make certain sounds or only talk or say a few words without having to gasp for another breath, then we can say that that's not adequate. So what's considered adequate? Remember, they have to have the ability to breathe deep enough. Remember, they have to have good rate. There shouldn't be any gurgling or pitching, squeaking or whistling as they're breathing, right? And they have to have the ability to move oxygen through the oral and nasal pharynx, through the larynx, right, into the trachea, and then down to the alveolar sacs, right? And so the depth of their breathing also has to be efficient. So what happens if we have the unconscious patient, right? And in this case, what we would say is that you're going to get into a different position. You're going to kneel down to that patient, and you're going to open the airway with a head tilt chin lift, and you're going to put your ear close to the patient's mouth. You're going to put your cheek about 2 inches away from the patient's mouth, and you're going to turn your head towards the patient's chest. And what you're going to basically do essentially is you're going to look for breathing with the chest rising and falling. You're going to listen for breathing with your ear by the patient's mouth. And then last but not least, you're going to feel for breathing with your cheek, right? If they are breathing, you will feel their breaths on your cheek. You're going to do this for no longer than 10 seconds. If you look, listen, and feel for no longer than 10 seconds, and you determine that the patient is not breathing, it's then that we would start artificial ventilation. Okay? Artificial ventilation. So there are several different ways that we can administer an artificial ventilation to our patient. I think the least talked about is mouth to mouth, and the big reason is because of the incidence or the development of a pathogen being introduced to you as the first responder. And so the recommendation by the Red Cross and the American Heart Association is that you would not perform mouth to mouth in the event that you do have a resuscitation device, such as a resuscitation mask or another barrier. I would say that if it comes down to morals and it's just you and you don't have your resuscitation mask, to go ahead and resuscitate the patient, but you are not obligated by any means to perform mouth-to-mouth resuscitation on victims in the field if you do not have a barrier. Again, it just comes down to your morals. Do you want to save a patient's life, or do you want to avoid a potential lifelong illness, I guess, is the question that you should ask yourself when you enter in an emergency situation without a resuscitation device. The gold standard for artificial ventilation is a resuscitation mask, and I think the resuscitation mask probably the gold standard because they are easy to carry. They're very small. They take up little space. They are very pliable in nature, so they can fold, bend, in some cases bend, but they can be placed in a situation under a lot of pressure without any give, without causing the balloon portion of the resuscitation mask to pop, which is right here. There is an inlet for oxygen, which is this guy right here, and then what we would call a one-way valve. So a one-way valve is a valve that allows air to go in, but not air to come out. And so how does this protect you as a first responder? Because air can't come out, that means that the patient, if they were to become conscious or if they were to vomit, cannot go up into the valve and come out into your mouth. So you're protected by this one-way valve. Some masks are produced with what's called an oxygen inlet, which again, if you think about this, is just basically allows for oxygen administration to occur. So you can use the mask over the patient's face and attach oxygen to the mask so that oxygen can be delivered. The nice thing about resuscitation masks is that they are both good in hot and cold environments, and they are the easiest barrier to use in the field. So when we think about resuscitation masks in general, how do we use these masks? It's very simple. We're going to attach the one-way valve to the mask, which we'll do in lab. We'll practice doing this in lab. And then the other thing that we're going to do is we're going to position the triangular portion of the mask over the patient's nose, and then the base of the mask over the patient's chin. And this allows for us to get a good seal. So again, make sure you're getting a good seal so that all of the oxygen is going into the patient and not into the environment. And then if you can, you really want to use both hands to keep the mask in place, and we'll utilize what we call a diamond position in lab to secure the mask to the patient's face. So what are some of the advantages of using resuscitation masks? I think one of the biggest advantages is that you really do have this increase in flow from your lungs into your patient. But the big advantage again is that it really allows for an adequate seal, which means you get increased O2 being delivered to your patient in a sense. And then we get the idea that with this particular attachment, we can actually attach supplemental oxygen and deliver oxygen to our patient as well. The number one reason that we use a resuscitation mask is really to decrease the risk of disease transmission by avoiding pathogen being transmitted to the first responder in the process of artificial ventilation. The next type of device is a bag valve mask. It's a handheld device that is a lot bigger when we compare it to the resuscitation mask. And just like the name implies, it really consists of the bag, the valve, and the mask. And so if we were to label these, we'd say this would be the bag of the bag valve mask. This would be the one-way valve right here. And then last but not least, we have the mask itself, which fits over the patient's face. And so when we think about the bag valve mask, the big deal is, as a first responder, you're going to be using one hand to to squeeze the bag, and then the other to hold the mask in place sometimes. And so with the bag valve mask, one of the big deals is making sure that you are squeezing enough air into the victim's airway to deliver enough oxygen to be supplied to the rest of the body. So how do we use a bag valve mask? The recommendation as of 5 years ago is that in order to use a bag valve mask, 2 rescuers must be available. So that goes to the disadvantages here, which is that it's very difficult for one responder to use the bag valve mask and be good and efficient at it. And so again, the recommendation is that at least 2 responders must be available to deliver artificial ventilations with the bag valve mask. One rescuer is going to hold the mask in place on the victim, and then the other rescuer is going to be responsible for squeezing O2 into the victim's airway. So we get two rescuers using one resuscitation device. So one rescuer, again, like I said, you're going to put the mask over the patient's nose and mouth, and then the other rescuer is going to squeeze the bag with the other hand, i.e. delivering artificial ventilations. One of the biggest advantages when we compare it to the resuscitation mask alone is this idea that it delivers a higher concentration of oxygen, which is good. Remember, we breathe in about 21% air, and then of that 21%, we only really need about 5 to sustain life. So we kind of increase that chance of getting at least 5% into our patient's airway so that it can be delivered to the alveolar sacs to where gaseous exchange can occur. The other disadvantage to using a bag valve mask is that sometimes it does have to be assembled, and that takes time. Remember, we have about 0 to 4 minutes truly to deliver oxygen to our patient before they are brain dead. So this particular scenario presents a case where you have a patient who has what is called a stoma. A stoma is a hole in the patient's throat, typically around what we would call, the Adam's apple, but it's when a patient has had the larynx removed, right? And so remember, the larynx provides transmission of air from the trachea to the lungs, right? And so when we remove the larynx, what we have to do is we actually have to breathe over the patient's stoma, and so that becomes a little bit different. It no longer is mouth to mouth, it is what we would call mouth to stoma. In doing so, what we have to do is that we have to make sure that when we are breathing through the stoma that we cover the patient's mouth and the patient's nose. Otherwise, as we're breathing through the stoma here, air would be coming out of the patient's nose and out of the patient's mouth. So we have to make sure that as we're breathing into patients with a stoma that we are doing it correctly. Cover the patient's nose and mouth and breathe directly into the stoma. As always, you still want to give breaths into the stoma at the same rate that you would if you were doing it from mouth to mouth or mouth to mask. And then obviously remove your mouth from the stoma between the breaths to allow any excess air to be removed from the lungs themselves, and then go back down and give your breath again. Someone asked in a recent class session, well, a stoma, do I really have to? Again, you do not have to. The big deal is that you're saving a patient's life, so just cover their mouth and nose and go down and give air into the stoma itself. Risk of transmission in terms of disease transmission probably decrease when compared to breathing or rescue breathing into a patient's mouth directly, because you're breathing into their throat, and so that's just something to keep in mind. So one of the special populations that you might encounter in the elderly population are patients with dentures. One of the rules of thumb is really to not remove the dentures. Some people automatically want to remove them, but the cool thing about not removing the dentures themselves is really that they actually provide some structure and integrity to the mouth, which actually provides for better, more efficient artificial ventilations for your patient. So if you do not have to remove the dentures, let's say, for example, the dentures, when you apply pressure with the mask, they fall to the back of the throat and they obstruct the airway. In that case, we would remove the dentures. Otherwise, if they do not obstruct the airway, we want to keep them in because they provide more structure around the mouth and provide and allow us to get a better seal on our patients. Again, with suspected head, neck, and back injuries, the big deal is we want to minimize movement of the cervical spine, and so we're going to use the jaw thrust technique. We'll do this in lab. So as a recap, when we talk about children versus adult and airway, we know that they have different airway structures. Again, remember the tongue is huge when compared to the adult. Children have smaller mouths and smaller noses. And in addition to that, their trachea tend to be a little bit more fragile and more susceptible to fracture. So again, tilting the head back too far might actually cause more harm than good in your pediatric population. And so uncorrected breathing emergencies in children typically coincide with cardiac arrest. So if we can correct the respiratory pathology, then we could prevent cardiac arrest in children. So a big deal is making sure that we recognize that we're able to determine whether or not the airway is open and that the child is breathing. We could prevent a lot of cardiac emergencies that we see in our pediatric population. And then last but not least, with our children or with our infants that we encounter who are not breathing, rescue breathing becomes even more crucial than it does for an adult. Again, when we think about the idea or the potential of our patient developing brain death or our brain cells dying off, it tends to be exacerbated, or the time that we have to actually start rescue breathing tends to be decreased. So instead of having 0 to 4 minutes, you might have 0 to about 2.5 minutes to start providing treatment or to start breathing for our infant population. So with assisted breathing, what we're really referring to is oxygen and oxygen administration in our conscious patient. So we're talking O2 admin to a conscious patient, and we're going to talk about that in detail in the next slides. So as a first responder performing artificial breathing, there are special considerations that we should look for. The big one is air in the stomach. If air is getting into our patient's stomach and the stomach is becoming distended, the big deal is that it's either your breathing is way too long, so you're breathing for too long. Your breath should last no longer than about a second. Any longer than that, and they say that air starts to go into the esophagus and your patient starts to look like this, where their stomach is very distended. If the victim's head is not back far enough, then you're not getting enough air into your patient. And if you give breaths too quickly, right? You give breaths too quickly, they tend to bypass the trachea and go into the esophagus. And again, you get a patient who looks like this, which is gastric distension. Too much air, so the trachea can't bring it all in, and it bypasses the trachea and it goes into the stomach or the esophagus itself. Well, what's the big deal with a patient that looks like this? It's vomiting. So if you don't want your patient to vomit, then we have to make sure that we are breathing adequately and efficiently for our patient, and that really involves breathing no longer than 1 second. So if our patient vomits, all we're going to do is we're going to turn that patient onto their side and put them in the recovery position. We're going to wipe out the victim's mouth, and then we're going to start our rescue breathing all over again. So I think we've seen this before. Big deal. Step number 1 is scene safety, right? We want to survey the scene. We want to make sure the scene is safe. We're going to tap the patient. We're going to ask them if they're okay. If we get no response, then the next step would be to check the patient's vitals, airway, breathing, circulation. If there is no breathing, then we immediately go into the process of rescue breathing. We will perform rescue breathing in lab, but in short, it's 1 breath every 5 seconds for an adult, and it's 1 breath every 3 seconds for a child and or an infant. So again, rescue breathing, 1 breath every 5 seconds. And then for a child and an infant, it's 1 breath every 3 seconds. And then we're going to recheck airway, breathing, and circulation every 2 minutes. Now, again, the head positioning, as you can tell, with an adult, it's all the way back because we're not worried about their airway structures. However, with an infant and a child, we are worried about the trachea specifically, and then the tongue being an anatomical block. So we want to make sure that our head isn't tilted back as far as the adult. Please note the head positioning here, and then our ratios for rescue breathing here. So in summary, if I had to summarize this entire lecture, I would say that if your patient is breathing, but breathing inadequately, you must assist as a first responder. You're going to provide ventilations while the patient is inhaling, or try to breathe on or trying to breathe on his or her own. Since inadequate breathing is often slower than usual, I think it's important that you will need to know that you have to provide additional ventilations in between the patient's own attempts to breathe. And then if breathing is rapid and very shallow and therefore inadequate, provide assisted ventilations when the patient begins a respiration. You will find that when you're providing a ventilation, that if you do it while the patient is exhaling, that this can create resistance and some type of random noise. For homework, what I would like you guys to do is to analyze this chart right here and to tell me what this means to you. I will see you next class period. Be ready to discuss this chart in full detail.